There we go. So it's officially recording now. Welcome to the open forum here on February 20th. My name is Dr. Karen Duncan, and I am coming to you from Coeur d'Alene, Idaho at the clinic here. And our open forum topic today is, remind me what this is, an integrative approach to memory, right? If I say I forgot, is that like the oldest pun in the book, the oldest joke for talking about memory care? Any of my patients who do know me know that I make really terrible jokes, but it's all in an attempt to provide comfort and ease in the clinic experience. So we are going to talk about an integrative approach to memory care. I could sit here and talk. I'm going to rely on the two live participants here a little bit to ask questions if you feel comfortable. I do a lot better, I would say, in an interactive environment where there is questions, there's curiosities, things like that. But I will always have plenty to talk about for the 30 minutes that we're meeting today. I just want to make sure that it is beneficial to not just those of you who are tuning in live, but the ones who might watch the recording later. So what I'd like to start with is just what it looks like. You walk into my office, you say, hey, I think I'm having some memory issues. Here's what I'm noticing. What are the first steps we take? Why do we take those steps? What are some of the tools that we use? And what are some of the results that we're seeing? My mentor and one of the greatest practitioners, I think, on the planet, Dr. Lori Mishley, is researching herself in the world of Parkinson's disease to show that what she's doing for her patients is actually working. And she has brand new research that's about to, hit the web, which I'm so excited for as she's collecting data. But in the trajectory of Parkinson's disease, where it tends to be a neurodegenerative condition, her patients overall are following an inverse slope, which is really exciting. So they're actually improving over time. And I think it's really, really important. And she's always been so humble in this, but being in clinical practice now for 5 years, being able to tell people that, like, hey, we're not just doing this because one, the research shows it, or two, we know it works biochemically, which is kind of my go-to because I love the why. I love why this is happening and how it happens in our body. But also to say, hey, look at my patient list. These people are seeing real results by utilizing these protocols. That's really what people want to see. So it's exciting to be here. It's exciting to talk about memory care. I'm passionate about it for multiple reasons. But for those of you who don't know me well, I did lose my dad to a brain injury, and over time kind of wore away at his personality and his memory. He's still physically alive, but definitely, dabbling in that ambiguous grief piece where he's alive, but he's not really him anymore, and his memory is impaired. And so at the age of 14, I fell in love with the human brain and the mysteries that it holds. And the cool thing is deep into my clinical practice, I still love the mystery of the human brain. I still love that it can surprise us. I still love that we don't know all the time, because it allows me to be really creative in my practice and not follow algorithms, which I wasn't cut out to do in the first place. So what does it look like when you make an appointment and say, hey, I want to see Dr. Karen. I think I'm having some memory impairment. Well, the very first thing I can tell you is you're probably too late. Once you get to the point where you think you're having memory impairment, it probably has been happening for a while up until then. And I'm on record. I think I talked about memory last year in an open forum as well, almost in like a please come see me earlier, is because there's so much fear surrounding the potential of having something like Alzheimer's or dementia or Parkinson's or any kind of memory impairment that most people that I meet will put off their symptoms to age. And it's not just them, right? Their providers will say, oh yeah, well, at your age, a lot of people are forgetting things. Their friend group, they'll say, oh yeah, I forgot what I was doing in the kitchen too. So a lot of people, when they recognize symptoms, will cast it off towards something else. And am I saying that it's always memory impairment? No. But what I am saying is trust your gut. If you're recognizing something about yourself that doesn't feel right and it feels like there's some fear around it and you don't want to bring it up to somebody, then it's probably time to bring it up to somebody. And the best case scenario is that you go and you get evaluated and you go through the steps. And I say, hey, I don't think this is organic memory loss. I think this is X, Y, or Z. And we'll talk about what those options are. but living in that anxiety and fear spiral about memory loss can actually contribute to memory loss. So that's why I say, if you feel different, if you feel like it's not natural or normal for you, then try not to cast it off as normal, and don't let somebody else tell you this is just normal either. As an aside, I personally believe ageism is one of the biggest offenses in our medical world. And so if anybody uses the phrase at your age to dismiss a concern that you have, then maybe it's time to find somebody who doesn't use that phrase, is what I'll say, because it's just not appropriate. There are some things that are going to be age related in our health, of course, because we don't live forever. However, this doesn't have to be one of them. So that's my little soapbox about that. So you walk in, you say, hey, doc, I think I'm having memory impairment. And in this office, what I can say is actually might be good opportunity, people who don't know my office, is it doesn't look like a regular doctor's office, right? It's comfy, it's cozy. We're going to sit down. I usually have a coffee. I've got a little squishy brain over there. You sit on the couch and we're just going to have a conversation. And I'm going to say, well, tell me why. Tell me why you think that you're having some memory issues. And you're going to tell me what you're experiencing. If you're bringing a loved one and they're recognizing that you're having impairments as well, I'll probably rely on them sometimes later in the visit. Oftentimes I'll ask them to be quiet just at the beginning, because it's really important for me to evaluate that cognitive function. Most of the time they have these different questionnaires and they have these different evaluations that physicians do with patients who are experiencing cognitive impairment. One of them is like the mini mental status exam. There's a lot of different labels for it. And so what I do in my practice is I make it conversational. So instead of asking you blunt questions, we will get to know each other, and I will be able to ask you and evaluate your remote memory, your short-term memory, your recall, you know, different cognitive issues in that way. And it makes it really comfortable. So then I can, by the end of the visit, have a pretty good objective idea of how your memory is working, how your cognition is functioning, without then saying, hey, you need to answer these 5 questions and remember these 5 words, which puts everybody into an anxiety spiral. And then if they don't do well, then they're like, oh my gosh, I failed. So that's a really good opportunity to do that. If you do come with somebody, a loved one, then typically if you're way off base and you're answering all the questions wrong and conversationally you're missing things in history and you don't know your wedding anniversary or whatever the case may be, they're going to make faces, right? They're going to be like, they want to talk, they want to participate, and I can read that body language. And then about 20 minutes in, I'll say, hey, let's pause right now. I just want to verify some of the things that you're saying, if they're true, if they're accurate. Let's check in with your loved one here. And that also helps give a little bit more of a vignette of where are we at as far as the impairment is concerned, if it's actually present. What I recognize all the time is, this is especially in spouses, is that if you've been married for any length of time at all, you're automatically finishing each other's sentences anyway, and you're kind of like joint doing the visit. So it can be really uncomfortable, and people will get a little squirmy when I take that person out of the conversation. And that's also helpful to recognize, like, hey, how much of this could actually be a crutch if there is actually memory impairment happening that we need to eliminate to ensure we're getting a good evaluation. At that time, I typically will ask some pointed questions that gives me objective data. Hey, when was JFK assassinated? When did 9/11 happen? Who were the last 4 presidents? What does this abstract phrase mean? Don't cry over spilled milk. Give you a few words to remember and then ask you later on to repeat those words. So those are more obvious cognitive tests that we do right there in the visit that just help me kind of identify if there's anything missing in the meantime. That very first visit, especially when cognitive impairment is a primary concern, is the best opportunity to talk about childhood. And it's really, really odd for most people to understand why I want to know your narrative or your history or your story. But I do have an open forum lecture that's titled Adverse Childhood Experiences and Cognitive Decline. And the tie-in there is so profound that it's a necessary piece of the evaluation for me. And I compare it to heart disease. Like any Joe off the street, if I doesn't have to be a doctor and I say I want to screen somebody for heart disease, people can say, oh yeah, if they're a smoker, if they're overweight, if they're sedentary, if they eat a high-fat diet, right, they're at risk for a heart attack. Anybody knows that. My 5-year-old probably knows that. That's common knowledge. But what we're not doing, and Dr. Nadine Burke-Harris is actually the one that does a brilliant TED Talk on adverse childhood events in chronic inflammatory conditions. We know that this is a correlative risk factor downstream for cognitive impairment. And the fact that most practitioners are not screening for this is a disservice to our patient. And so a lot of times, if there is trauma in childhood and we have oriented to the world as it being unsafe, which puts us in the sympathetic nervous system's tone for most of our adult life, which is that fight, flight, fawn, and freeze tone, then the majority of our brain function is running through our limbic system, right? That's run by the amygdala, which is, sparked by fear or strong emotion rather than logical thinking through the executive function of the prefrontal cortex. So we do spend quite a fair amount of time in the initial visit talking about your childhood. What was your life like? And it's not just childhood trauma. Did you have a divorce? Did you have a giant grief? Did you have an accident, an injury, a concussion, seizure disorder, a chronic illness, right? Did you have COVID? Have you had mononucleosis? Do you have herpes virus? Did you ever have a syphilis infection? I want to know everything about you to a cellular level to understand what could impair your cognitive function. Because like I said at the beginning, the brain is still a mystery. We still don't know why certain things happen. So I consider myself as you have this concern, which is this huge bucket saying, I'm going to blame everything on my brain. And my job is to go sift through that bucket and say, oh no, this might be this. This might be because of this. This might be due to something different. And as we pull those out and start healing those different pieces, we actually can see cognition improve in a lot of cases. So that's the initial part, is you tell me everything you know about you. I'm going to take that all on board. I become a sponge. At the same time, I'm secretly and creatively, now anybody who's watching this who comes for a first consult knows I'm going to be secretly and creatively judging you and evaluating you in conversation. But to kind of understand that mental status piece in a functional way. So I'm going to pause here and see if there's any questions for those who are joining us live, and then I'll kind of keep going at what the approach looks like from there. And welcome, Betty. You jumped in a little late, so I didn't give you a proper welcome, but I'm glad you're here.
Dr. Karen, I just wanted to mention that I need to leave here at 4:15, and I didn't want to interrupt. So if I tune out, it's just because I have another commitment. But yeah, I wanted to ask, because I don't live on site and it'd be hard for me to get to Coeur d'Alene, is there work that we could do online? I'm sure that's a question that a lot of people ask.
Absolutely. Yep. I do telehealth visits. And so a lot, especially when it's cognitive, unless there's profound cardiovascular disease or something that I need to be physically examining you for, I work well with your care team that's already established, that's seeing you in person. And yes, everything can be done remotely for the most part. So
Right. Yeah, especially I know there's a series of tests that you like to do, and that
yes,
can be
yep,
done. Yeah.
that can be done remotely. And we'll talk about what that testing is. So good.
Okay, thank
Good
you.
question. Yep. And the event is over at 3:45. So you should be right
Perfect.
on time. So
Great. Thank
that
you
works
very
out
much.
well. Absolutely. So the very first step, like I said, is kind of like peeling an onion, right? Like, what are the different layers to this? The very first thing that I run is a comprehensive neurologic panel. And that is everything from your immune function to your liver and kidney function, which is your standard, CBC, your CMP14. I'm going to run an A1C paired with insulin, because I want to see not just what your blood sugar is, but what is your metabolic function with your insulin resistance, or if there's not. I'm going to run a full thyroid panel. I'm screening for hypo and hyperthyroid. It also gives me a glimpse into if there's any autoimmune activity happening in the body. I'm going to run an iron and ferritin. For some reason, iron and ferritin is not standard of care in our patients, especially our Medicare patients. And I would say at least 50% of the time when I run labs, those are off. They're either too high or they're too low. And that's a huge contributing factor to oxidative stress in the body if they're too high, and a huge contributing factor to energy, brain fog, dizziness, function if they're too low. I'm going to run your B12, your B6, your vitamin D. Want to run a urinalysis, because if you didn't know, women over 60 who have subclinical urinary tract infections can show up as cognitive decline. And that's the only symptom that they notice. And it can be festering for months. I think I said vitamin D. I'm going to look at your lipids. I'm going to look at inflammatory markers. It is a comprehensive panel to say, I don't want to just know that you're alive, which is what your kind of standard labs are doing in the conventional world. I want to know how your body is doing, not just if you have enough vitamins, are you metabolizing your vitamins? Are you inflamed? And so we really take a deep dive into how your physiology is working, because there are so many things that can be abnormal in a lab workup that mimic cognitive impairment, that's what I say is kind of the closest alligator to the canoe, right? If there's something off there and we're treating you in a different realm, it's an obstacle that we would need to correct to get any benefit from there to begin with. If you present with any digestive concerns, nausea, vomiting, bloating, gas, constipation, diarrhea, reflux, hey, I've had IBS for my whole life. We know the gut-brain axis is so profound in our cognitive and brain health that inflammatory process of the GI system is directly correlated to brain function, that's going to be another route that we address to say, hey, if your gut's inflamed, one, you're probably not metabolizing your nutrients, you're probably not absorbing your nutrients, and you're not detoxing your toxins well enough, because your colon is 20% of your detoxification function in your body. So that's, as we continue to pull back those physical clinical evaluations, those can alleviate stress and inflammation on the body. I kind of alluded to before, we blame the brain for a lot. And to be honest, ever since my dad's accident when I was 14 until I started practicing medicine, I blame the brain for a lot. This is brain disease. This is what we're doing. We're trying to heal the brain. But the longer I'm in practice and the more that I learn, the more I really give the brain a break. She's just a motherboard up there trying to make sense of the external world and the internal world. And she's receiving, or he is receiving, all these cues, which is called neuroception and interoception, and getting it all fired at it. And then it's trying to make sense of it and sending out responses. Are we nervous? Are we scared? Are we excited? Are we going to make our heart race? Are we going to give you a stomach ache? What those things can do is kind of get your wires crossed. And that is really important to me to have people understand, like, your brain might not be broken. This might be it just responding to the cues in its environment and not knowing where to go or how to respond. So those are some objective tests that right off the bat, I like to run and address. Now, in the meantime, we're definitely looking at your diet. We're looking at hydration status. I often joke with my husband, I'm the best paid physician on the planet that tells people to drink rich water, because none of y'all drink enough water. We need electrolytes. We need that support in our system. So those things are really, really beneficial for us. We need our antioxidant foods. We need fiber. So those pieces are so intricate. The best prescription I can write for brain health is exercise and movement. I always say your brain is an extremity. So for my male patients, I like to say, if your penis isn't working, your brain's probably not working either. They're both extremities, but your blood's got to go against gravity to get to your brain. So if you think of it as an extremity and against gravity, the best way to get blood up there and oxygenation and nutrients is to get your blood pumping and actually to do cardiovascular exercise. And if I could put it in a pill bottle, I would. And so we really start to chip away at it as that goes. Now, in the meantime, as we're doing this evaluative and investigative work, there are treatments that really do help with cognition. We look at your sleep. How do we make sure that you're sleeping fine? Again, I already talked about digestion and bowel habits. There are certain herbs that can really help with somebody's anxiety levels. And so there's a lot of what I say palliative care that's, I say, non-invasive and doesn't have a big side effect profile that can really help organize what's going on in your thought pattern, that just by getting that in line, people's cognitive scores will improve. When I talk about cognitive scores, the standard of care in a primary care office is something called the MOCA. I don't know if anybody's seen this before, but it's the Montreal Cognitive Assessment. And it's a test that I'll perform on most of my patients who are concerned about cognitive impairment. It's an in-office test. It takes about 30 minutes. It's not timed and it's not diagnostic. But what it does do is it gives us an idea of how your cognitive function works. It does delineate between a few different regions like visual, spatial, executive decision-making, naming, memory, attention. And so it gives me an idea of not just how you're functioning, but what lobes of your brain are functioning better than others. And then the really beneficial thing about doing this in office is even though I have to be a robot, like I tell people, my charm, wit, and humor go out the window when I'm giving this test, but I can watch you take the test. So if I'm telling you, hey, you need to draw this cube, and you're drawing it and it's completely wrong, so I can't give you any points, but out loud, you're going, I know I have to make these parallel lines and I correct them there, and you're kind of narrating what you're doing. Then how I score a test is objectively, yes, I'm going to give you a score of 16 out of 30, pass fail kind of thing. But I can write in my notes, that's a 16 potential 20. She had it all the way up until the end, and I couldn't give her the point for the clock because she didn't put the long hand in the correct place, right? But she talked her way all the way through it. So I know she can get a point on that. It just might be attention or anxiety sitting here with me. And so I'll still score it appropriately for that objective measure, but I will always make those subjective notes to myself that are like, hey, I think they can do better than this. Or the opposite might be true. I think they just guessed at that and pulled that one out of you know what, and their cognition is actually a little bit worse than what they're demonstrating. That's usually a screening test, like I said, that I will use. It's not very in depth, but it's really nice, and especially for my patients who are not tech savvy, who can't use a computer program. So that computer program is called Krayos Brain Science. And why I really, really like the Krayos Brain Science functionality is because it's clinically proven and all the research is up on their website, and you can always do evaluation or investigation there. But I'm just gonna cross a couple things out here so I can share with you on here without violating anybody's privacy. And this is a precursor to, let's just say somebody had actual cognitive decline, but they could still use a computer just fine. I would send them this Krayos Brain Science questionnaire, and similar, it's not diagnostic and it's not standard of care, but I work with a neuropsychiatrist here in Spokane, and she and I work really well together because one, she's booked out 6 months. Those tests are really expensive. They're really anxiety provoking for patients because you have to go in somewhere to do it. And so what she tells me is, hey, do this evaluation. And if they're not doing well and they consistently don't do well, then send them to me. But it's a great screening protocol to say, do we think that you need an actual formal diagnosis? So it's this whole workup for that. Hi, Marcia. Thanks for joining us. So what the Krayos Brain Science does is it divides it into 2 sections. We have a subjective again and an objective. The subjective is questionnaires like the GAD-7, generalized anxiety disorder, the PHQ-9, which screens for depression, the ASRS, which screens for attention deficit disorder, an audit test, which will screen for substance abuse, PCL5, which tells me if you have PTSD, post-traumatic stress disorder, and then a PSS, which is perceived stress scale of, hey, your anxiety might be low, but if you're perceiving your stress to be high, then you're kind of dissociating from that perceived stress by not having anxiety. So that's often like, hey, I'm easily overwhelmed. I'm easily distracted. I feel really out of control if I can't manage something. And so looking at those subjective questionnaires, I can take those scores and correlate it with the objective testing, which we'll go through in a moment, to say, hey, you are having cognitive impairment, and I can see that on your test scores, but your anxiety is at 15. And if we worked on how anxious you were and how your nervous system is in that fight or flight all the time, could we actually improve your cognitive scores? And I will say 9 times out of 10 clinically, yes. Yes, you can. And there's, I mentioned ACEs before, there's counseling work, there's trauma-informed counseling. They're sitting with the care partner saying, you can't create anxiety. If they forget to write a check and you're on them, then that's going to create more anxiety, which is going to create more forgetfulness. So there is a piece of that that's, family counseling oriented. And then we retest those scores every 3 months, and we do different treatments, we do different protocols. We're addressing your lab values, we're addressing your digestion, and then we retest your score. And we're looking for objective improvements in cognition and subjective improvements or improvements in your subjective scores like anxiety and depression. And so just to give you an idea of what that looks like. So this is the PHQ-9 And it's just a questionnaire telling me, hey, do you feel like you have depression? We've got the GAD-7. So they're all questionnaires that look like this that you're going to fill out. And then the cognitive assessment will give me an evaluation that looks like this. So you'll do 12 different tests, and then it's going to score you, and it's based on age and gender. And so they're taking that. So you're not being compared to, you know, a 40-year-old male if you're a 70-year-old female. It's going to be all gender and age match control. And then the really cool thing about this is we can see over time. Once you take this multiple times, you can say, hey, I saw objective or improvement in your scores over time, or hey, we're seeing them actually go down over time. And I'm looking here for this. So in this particular patient, we can see that her scores were decreasing in a meaningful way with every subsequent test. And what this is helpful for seeing is, hey, do we need to change our treatment? Do we need to be more assertive and do more testing? A lot of times we actually see those scores improve, and again, it's meaningful change. So is it statistically significant over time with different treatments? The benefit to doing this, the comparison I make is like it's a lab value for your brain, right? We can't run labs to see how your brain is functioning, but we can every few months retest you with this very standardized protocol that says, with the changes that we've made, we gave you B vitamins, we gave you something for your anxiety, your sleep has improved, your digestion has improved. Let's go retake your cognitive test and see how that shifted and changed for you. The really cool thing about Craos is they take into account the fact that you've seen the test before, where the MOCA test doesn't, right? Every time you come in, every 3 to 6 months, you're going to name a lion, a rhino, and a camel. And there's going to be some sort of memory bank that's going to keep that in mind, and you could improve even if your cognition at home isn't. The Craos brain science is going to be way more indicated for people who actually are showing signs of clinical decline because or cognitive decline because they're taking into account that you've seen the test before. So each subsequent test means you have to improve even more to mean that it's significant change. I hope that makes sense. So it's very drive that way. And so that's when, let's say it is present, then we move to a different treatment protocol, refer out to neuropsychiatry for the standardized test to see if you need more support in that way. And then we continue to manage your care from there. I'm going to pause again here because I just covered a lot and it was kind of heavy on the science front and the testing front, and just see if anybody has any questions as far as what that process looks like.
My questions are a bit practical.
Sure.
What, does any of this, is any of this covered by Medicare?
Unfortunately, it's not. So Medicare doesn't cover any of my time of service as a naturopathic doctor. And
Yeah,
and that's really all the cost is. The Craos Brain Science, what I can say is I partner with them specifically as a physician. So that's outside of my practice. And it's a subscription fee for me. And I usually come out about even. And so when
right,
I talk to my rep, every single year, they're like, you need to charge more, you need to charge more. And I'm like, look, if I'm coming out even from what I pay you and what I'm charging patients, that's what I'm looking
right,
for.
right.
But there are physicians across the country that are using this as a primary screening tool that is their only means of income. And so I'm not trying to throw anybody under the bus, but I just, be wary about that because you can just pick how much you want to charge for this. And then,
Right, right.
some people are charging up to thousands of dollars to do this tool
Mm,
when it's not really necessary. And so when we do that, just because I'm seeing more patients now, so on a very practical level, and I'll be transparent, I have this cognitive assessment out now to several hundred people in my database. And so my
yeah,
cost of subscription goes up. So that's where, if we have cost changes there, but right now I'm charging $400 for 4 tests. And so
right. And you
that's a
said there was
$100
something
per
in
evaluation.
February, there was some special in
There is
February.
a special in February. Yep. So
Huh?
my hope is that, in Heart Month in February, and we just try to get our brains in gear too,
Right,
piggyback on the month. But it's really to say and like I mentioned at the beginning of the visit, and Betty and Marcia weren't here, is by the time you're approaching your physician about cognitive impairment, you're probably a little bit too late because it's been festering and you've been worried about it and you've been thinking about it. And we
Right,
really want to be on the front end of this. And
right.
that's why I love this tool, is that you do it from the comfort of your own home. It takes an hour and a half to complete the assessment. I evaluate it with a fine-tooth comb, give you guidance right off the bat, and then we continue to meet on your health needs. Like I said, your blood labs, your digestive function, everything else.
Mhm.
And we use that whole person centered care to improve those scores. And if
Mhm.
they don't improve, then we're on the very front end of saying, we need to get treatment. We need to do something more drastic before it's impairing your quality of life.
Mhm. Yeah.
Does that answer your question, Barbara?
Yes, it does. I think that my case is a little bit different maybe from other people because I am doing this long distance.
Mhm.
So continued care, once we do the assessment, if there
Yep.
is continued care, would it be possible for you to refer me to a naturopath in Portland that I could visit here?
Oh, absolutely.
Yeah, I
Absolutely.
think that would make sense because obviously I'd like to do some in person, continue in person if
Right.
possible.
I think that's great. The only thing there is I don't know anybody personally who's doing neurologic focused practice in the naturopathic world there, but I could always do research. We could work
Well, that would
together
be
and
terrific. Thank
look
you.
somebody up.
Thank
Because
you.
what I will say is that it is different, right? Like I talked about the labs, lab values, blood work values, and I have a whole lecture on this too because I'm passionate about it. We get normals on our lab reference ranges from the mean of the population. So really what that means is healthy 40-year-old white men is where we get our normal lab
Yeah,
reference.
that's helpful. Yeah.
And so when you're doing neurologic care, especially for what we would call the advanced age or aging population, whatever you want to say, we need to look at, yes, you might be in the normal reference range for something like homocysteine at 13. It's still in the normal reference range, but we know from our research that anything over 11 can be neurotoxic. And
Mhm.
so when we're looking at labs, I would want to find somebody that can discern some of those changes to say, this is affecting you. And like
Right.
I said, generalized naturopathic care, we could always, I will always work as a team. I'll just put it out that way. But get you going on that
Mhm.
protocol would be
Okay.
ideal.
Thank you.
Of course. Any other questions on kind of the approach? What I will say before we get ready to sign off here is that, the title of the talk is an integrative approach to memory care. And most people are really fascinated, I think, and surprised maybe when they come in and I'm asking them about their poop, right? My 5-year-old son doesn't tell anybody mommy's a doctor. He says, mommy talks about brains and poop. And he couldn't be more spot on. So when I'm talking, about digestion and thyroid function and iron levels and anxiety and childhood trauma, a lot of people kind of look at me and say like, okay, I came in here because of my brain. But really, when we're doing holistic and whole person centered care, we have to consider all of those because at the end of the day, like I mentioned, your brain is just a motherboard and she's taking in all of these signals of distress from internally and externally, and then trying to facilitate a response. And if there's fear involved, one of my favorite things to say is, if you have internal signals of distress, blood sugar dysregulation, lower high iron, right, high cholesterol, inflammatory markers, autoimmune disease, or thyroid disease that hasn't been tested, that is called interoception. And all of that is giving signals to your brain. And your brain is saying, oh my gosh, something's not right. We're not safe, right? At the end of the day, you're either safe or you're not. And that's it. And so if your brain is getting signals that suggest it's not safe, then her job is to find, or his job, sorry to my male listeners, is to find something to blame for it. And we could sit here for hours and pick things in our external environment, right, that we could blame for that. Family dynamics, financial stress, politics, the world at large, the plane crash that just, right? There's a million things that we could say, oh, that's why I'm anxious. That's why my brain feels off, right? That's why I'm so distracted. And so many people, like I mentioned in the beginning, will do that because it's easy and it makes sense because rarely does your brain go, oh, hey, Karen, your blood sugar's off, right? We don't have that ability to recognize it in that way. We just recognize something's wrong. And then I go, oh, well, it's snowing. How am I going to drive home? And am I going to be okay? Am I safe? And now my anxiety is going. And it has nothing to do with the snow, just because I just had a blood sugar crash. And so it's so important to recognize that the signals that we send to the brain, both internally and externally, have to be evaluated to determine what lobe of the brain is working. Um, the adverse, and then I'm going to sign off here, but the adverse childhood experiences, why is that so important? Well, for years, I was talking to folks, and my specialty is in Parkinson's disease, about dopamine and the limbic system and vagal nerve dysfunction, and how when we operate out of fear through our limbic system, you will never out arm wrestle your fear with logic, right? You're never going to say, oh, don't be scared, that's silly. You can say it, but your amygdala is just going to go, nope, we win. And then that anxiety is going to come up. So suppressed anxiety is stronger, or fear is stronger than any logic you could have. And so I would teach people that for years. And finally, God bless her, I had a patient says, okay, well, then how do I shut it off? If I can't logic it off, what do I do? And so I hit the books, and the answer is curiosity. Even if you know the answer to the question, if you ask it, it turns off that signal to the fear center. It creates that curiosity piece where then you're asking the question, and now your prefrontal cortex can answer it with logic. So you can't arm wrestle the fear, but you can ask the fear, hey, is this real? Is this a snake or a stick? Which is one of my favorite metaphors. And even if you know the answer already, asking the question is a trigger in your brain to send those signals to your prefrontal cortex instead. And you'd be surprised at the ability to find your keys. When you settle down, you do some breath work, you find out what's triggering you, and then you say, oh, I put my keys on the coffee table, right? It's being in that heightened state that's limbic center fueled that's going to exacerbate cognitive decline. And that's honestly, that's the majority of my work. I would say of everybody who comes to me with cognitive decline concerns, less than 25% actually have a diagnosis of cognitive decline. There's something else at play that's contributing to cognitive impairment that we can fix so long as we get to it early. Because that chronic state of fight or flight or thyroid dysfunction or anemia will indeed eventually lead to cognitive decline. So that's my PSA for get in early. Don't have fear about asking questions. Don't let anybody bully you into thinking you're too old to care, because ageism sucks. It doesn't have to be the norm. Is there a certain, my mom always jokes, this is the diagnosis of being older is, CRS. And she goes, I can't remember shit. And I always joke, I said, yeah, there's a little bit that entailed. But, mom, you also have ADD. Girlfriend can't hold a thought for more than 30 seconds. So, of course, you can't remember that. But now we have objective testing that says, if you can't, can we do exercises? Can you start practicing focused meditation? Can you do breath work? Can we check your neurotransmitters to see, do you have too much glutamate? Can we supplement you with GABA or lavender? Can we, there's so many things that we can do to support that process. And now, she's remembering things, and she hasn't forgotten her doctor's appointments, and she's, so many patients who come in at the end of 90-minute first visit, I'm saying, I don't think you have a cognitive problem. I think it's this, that, or the other. Let's run some labs. Let's prove it to be true. And if I'm wrong, we're here early and we're going to address it. So,
Well, thank you very much. That was a great introduction.
oh, good. Well, thank you for
Appreciate
being
it
here.
very
I know
much.
you have to sign off, Barbara. Thanks for
Yeah,
being here. The good
I will
question.
sign off, and others might want to carry on and ask more questions, but thank you
Yeah,
so much.
of
Okay,
course.
all right. I'll be
And
in.
then just so you know, Barbara, I do offer free 15s too. So if you did want to just call in the clinic and jump on my schedule to learn more about your particular case and how we would do that, we could always set that up for you as
All
well.
right. Thank you very much.
Of course.
Bye.
Sorry, I was late.
No problem, Marcia. Do you have any questions for me?
No, I was just, interested because I saw it in my, inbox, what you were up to. And I was confused because there were two support groups today and I got my times mixed up.
Oh, gee. That'll happen. And now you're on the memory and cognition impairment.
It's kind of ironic.
That's all right. Well, what I'll say about that, and I think the only thing that you missed from early on is just like what the beginning of a visit would look like if you thought you had cognitive impairment, how I assess the situation, what kind of blood tests that I want to run that would differ from like a normal Medicare checkup, how we support that process in general. So, that's really the part that you missed, and this is recorded, so you can go back and listen to the first half later if you wanted to.
Yeah, I was actually planning to tune into your earlier one that you did, but I thought, oh, she's on right now. Well, maybe I'll jump in there and say
Yeah.
hi.
And the promo that's happening right now, the reason that it's a promo is just to kind of like inspire people to be like, oh, I've been thinking about doing this for a while, or I've been concerned. and just to say, hey, like, let's put it on sale. Let's get people in the door. Let's get you assessed. Last year I did a promo and I treated over 30 people who are concerned about cognitive impairment. I only diagnosed 3 from that, that are actual, diagnosis of cognitive impairment or dementia. And from that, we're really working on optimizing health. Every single person who signs up to do the cognitive assessment, whether they're a patient or not, will get a 12-page report from that initial assessment that walks them through all of the results, what my initial findings were, what my initial thought process is, some different treatment options that are non-medical. Of course, if you're not a patient, I can't treat you that way. And then an invitation to say, do you want to do more? Do you want to do subsequent testing to learn about whether or not these protocols are beneficial for you? And it's been really reinforcing, I would say, to my practice and my passion to say people are stepping out saying, I'm not going to let anybody bully me into thinking this is my age. This doesn't feel right for me. And if there's something I can do about it, let's do it. I need an iron supplement. Great. My thyroid's off. Wonderful. That's a lot better than living in fear of cognitive decline for 3, 5, 10 years, instead of just fixing what might be at hand. So that's the part of my job I love.
Yeah, well, I'll be seeing you next month, virtually, of course.
Okay, well, you volunteered that information on a recorded video. But that's all right. I am gonna stop the recording now, and then I can, after the recording's over, if Betty or Doug want to kind of unmute and ask any questions, I'll open that up just for a few minutes here. So let me find the record button. Here it is. Stop recording.